Today, the cost of waiting got a price tag, and it's measured in billions. If you're just joining, DRC's Bundibugyo outbreak has stayed concentrated in the eastern provinces, but it keeps expanding. The last confirmed count was 1,759 cases and 600 deaths. 2 illnesses in Kisangani were still awaiting validation, including one with no clear geographic link beyond the city itself. And some frontline workers in Ituri had stopped work over delayed pay.
This is Ebola Watch. Today, a genomic preprint that may finally place those Kisangani cases, health workers under attack over rumors, and a billions with a B number for what delay actually costs. Kara, start me on that number. If you want to keep up with DRC Bundibugyo Ebola outbreak, tap follow so the next episode lands in your feed.
ISS Africa's Marvelous Ngundu is tracking this. The Institute for Security Studies put a number on delay today, billions in lost output across DRC and Uganda, and it reframes the whole week. The economic damage is now sitting right alongside the health system strain.
Finally, a number a skeptic can grab onto. Because do the humanitarian thing and this costs your economy billions land on very different desks.
But watch how the model gets there. It only works if delay is the variable, which means it quietly treats Kinshasa-Kampala border friction as a disease control lever, not background noise.
So what does delayed actually mean here? Delayed by how many weeks? At what transmission rate? Because billions without a denominator is just a scary word.
Here's Marco Silva, Peter Mawai at BBC.
The attack is one of a series of incidents linked to misinformation during the latest Ebola outbreak, which has infected more than 1,750 people and killed 600 in DR Congo since mid-May, according to government data. False claims circulating in affected areas include allegations that Ebola doesn't exist, that health workers are deliberately infecting people or harvesting their organs, and that the Ebola response is a money-making scheme.
Daniel Uyirworth-Welo, 27, a Red Cross volunteer, was grabbed from behind and hit with spades and machetes. His crime? Trying to bury someone safely in Bunia because a crowd decided the coffin was empty and Ebola isn't real.
And here's what makes that unbearable epidemiologically. A safe burial is one of the sharpest tools we have. Ebola spreads through the fluids of the dead, so when a crowd interrupts that burial, they're hurting Welo and creating the conditions for the next chain of transmission with their own hands.
Right after the ISS piece we just hit, billions in delay costs. Well, this is the delay. Every attacked worker leaves a gap in the tracing map.
Exactly. More than 1,750 infected, 600 dead since mid-May per government data, and the surveillance chain that's supposed to catch case 1,751 is being beaten off the field one volunteer at a time. Africanews is tracking this. The Bunia facility in this piece, the Evangelical Medical Center, is where the clinical trials are being staged, and the phrase is racing to adapt to growing patient needs. That's the tell. You don't race to adapt if you built for the caseload you're seeing.
Right, so pin it down for me. We had 628 in isolation and almost no beds left. Racing to adapt. Does that mean they added capacity, or are they still losing the race?
The article doesn't give you a new bed number, and I won't pretend it does. What it does confirm is that treatments are being stocked in real time. The candidate we flagged as in early trials, not on a truck, now has an enrollment site with patients walking in the door.
So the shelves getting filled while the room's filling up. That's the whole outbreak in one sentence, Sarah.
Tie that back to the ISS number we just hit. Billions in delay costs. That math only holds if these facilities stay open and staffed. Every day the Bunia Center is adapting instead of operating at capacity is a day inside that cost model. Virological writes,
On 15 May 2026, the Ministry of Public Health, Hygiene and Social Welfare, Democratic Republic of the Congo, DRC, officially declared a Bundibugyo Virus Disease, BVD, Outbreak in Ituri Province, DRC. This represents the 17th Ebola disease outbreak in DRC and the second caused by Bundibugyo virus, BDBV, the species Ebola-virus bundibugyoense. With the 2007 outbreak in Bundibugyo district, Uganda, and the 2012 BVD outbreak in Isiro, DRC, the ongoing outbreak is the third documented BVD outbreak.
The genomic side of this outbreak got a real upgrade today. INRB in Kinshasa and partners posted on Virological, and after weeks of sampling, they finally have enough sequences to estimate an outbreak-specific evolutionary rate, instead of borrowing one from past Ebola epidemics.
Okay, translate that for me. Why do I care whether they're measuring the virus's own clock instead of using a hand-me-down number?
Because a provincial case count tells you where people got sick. Sequencing shows you who infected who, the family tree of the virus. That's how you test whether cases in one place are really linked to the core outbreak, or just showing up nearby by coincidence.
So this could actually settle whether those Kisangani cases hang off the same branch. Not confirmed, but grounded in the genome now instead of guesswork.
That's the promise. And keep the scale in mind. Virological notes this is only the third time Bundibugyo virus has ever been documented in humans. Before this, the known human outbreaks were Uganda in 2007 and Isiro in 2012. Every genome out of Ituri is scientifically rare.
When WHO slaps a public health emergency of international concern label on something, it sounds enormous. But what does that declaration actually unlock? And what stays exactly the same?
That's fair skepticism because the label is powerful but pretty specific. A PHEIC, WHO's term, is the organization's highest formal alarm under the international health regulations. It sets off legal obligations for member countries, strengthen surveillance, share data, and coordinate at ports and borders. For this outbreak, WHO declared the emergency on May 17th, for the Bundibugyo virus outbreak spanning DRC and Uganda, according to the Director General's formal Article 12 determination under the IHR. By then, Africa CDC's count, reported by the Associated Press, was already more than 300 suspected cases and 88 deaths. And suspected matters there. WHO uses that word technically for cases that meet the clinical criteria but aren't lab-confirmed yet. The vaccine side is genuinely tougher than in past Ebola outbreaks. CDC's Health Alert Network advisory from May 19th says this is Bundibugyo virus, and there still isn't an approved vaccine for that species. The licensed vaccines cover a different Ebola species. What the PHEIC doesn't do, it doesn't automatically release a flood of pre-positioned doses, and it doesn't mandate border closures. Those take separate national and donor decisions. WHO was also explicit, per UN News reporting on WHO's own statements. The Director General said this does not meet the criteria for a pandemic emergency. That's a higher, separate threshold. So the risk right now is high regionally and nationally inside DRC, but WHO isn't signaling imminent global spread.
So, if there's no approved vaccine for this particular virus, what are health workers actually using to contain it right now?
That's the operational problem public health researchers keep pointing at. A PLOS Global Public Health commentary published in July called a lack of a Bundibugyo-specific vaccine a core gap, because it weakens the response options that worked in earlier outbreaks. Without ring vaccination, health workers are leaning hard on contact tracing, isolation, and treatment center capacity. Those tools work, but they're slower and tougher to scale across a border. Now watch whether donor governments use the fake to speed up funding for those ground-level systems, and whether DRC and Uganda's health ministries can keep cross-border contact tracing coordinated. That cooperation is the early warning signal for whether this stays regionally contained.
If you track Ebola with us, you might also appreciate Measles Outbreak Daily. Daily U.S. measles case counts, MMR vaccine policy, and outbreak tracking for parents, teachers, and clinicians who want real numbers. Find it wherever you listen to podcasts. You'll find links to every story we covered today in the show notes. If one caught your ear, you can dig into the source material there. That's Ebola Watch for today. This is a Lantern podcast.